which were in the amniocentesis probe, the partner went to a lawsuit, and it was resolved by this private practice. This is our biggest private practice in Berlin, by paying a huge amount of money to this family to not start a lawsuit. She was privileged to do it, but it was a very difficult situation. So never, if you lose the tip of the needle, retrieve and stop the procedure. Concentrate on the procedure, remain focused, the operator and the staff involved. I remember when at Sidra, I don't have a story for each slide, for each sentence. Don't worry, I will go a bit faster. But there was at the beginning, we were designing the rooms of Sidra, of the fetal medicine department, and they asked me, what do you think we should do? I mean, you know, the rooms are very nice, and the monitors on the wall, and everything is really, really fancy. And I told them, I don't want to have a phone in the room. And they were looking at me. A phone or a pager or something is disrupting. It's like doing a surgery. Take everything apart. Be focused when you do the procedure. This is what happened when you puncture around the umbilical cord in the placenta. The vessels can be very, thick at this area. And if you go through 2 vessels, you are lucky. But if you hit the vessel with the 22 gauge needle, it can start bleeding and bleeding and bleeding. Usually nothing. But if you do the amniocentesis too early, it can lead to fetal demise. You see the blood coming after the procedure from the amniocentesis. The second thing for the amniocentesis that is very, very important, there are a few papers on practical tips on how to perform. I took this one from the ultrasound in obstetric and gynecology, Journal of Obstetric and Gynecology from an Italian group. The bowel is between the muscle, I will show you later on a clip. The bowel is between the muscle and the uterine wall. You should always choose a route where muscle is in direct contact with the uterus. If you go too much from the side, you will go through the bowel, put E. coli in the amniotic fluid, and if the patient is not in a good shape, immune suppression for any reason, you can have a very, very fulminant sepsis. Okay? The patient doesn't have to die, but she can lose her uterus because there are also case reports about hysterectomy following amniocentesis. The risk of miscarriage is quite low, 0.5 to 1%. This is what is written in the consent. In experienced 10, I will say, centers that do them every week, Badr, Hamad, other colleagues, it's much lower, okay? And I think everybody has his figures. Extensive counseling is very important before the procedure. The patient has to trust you. And then she has to sign a consent. I remember in the 90s and 2000, we were doing 30 procedures a week because there was no NT around, there was no NIPTS. Everybody above 35 was having an amniocentesis, and many times we forget to sign the consent, and when it gets wrong, it's a really, really a problem. So signing the consent is very important before starting any procedure, especially at Hamad, and not signing with the patient lying already and then give her a pen, but sitting on the table and understanding the procedure. So this is a practical tip now. This is the way I do it. There are many, many ways. And maybe it will be interesting to know better technique. So usually what I try to do is to identify a pocket of fluid, okay? Then I move the transducer to the side, and I try to form an angle of 45 degrees between my transducer and the needle. It's very, very simple. Transducer in the middle, you move it to the right, take the needle, and then you have an angle of 45 degrees, okay? And then you will arrive at some stage in the pocket of fluid. The same is for the CVS. I took this picture from the publications. You do the transducer in the middle, you move it to the side, and then you have an angle of 45 degrees between the needle and the transducer, and then you get into the CVS. The important thing for an amniocentesis is not to push the needle very slowly because you are unsure about how to do it. It's very simple. You arrive to the myometrium with the needle, you stop a moment, you take your breath, and then you stick the needle into the amnio. Because if you move very slowly, you will cause what we call tenting, okay? And tenting has two effects. Either you don't get any fluid, and then you go somewhere else, and then you go somewhere else again. Or, if you have tenting, fluid will escape from the hole later on, and then you have what we call a complete chorioamniotic dissociation. This amniocentesis was done in a German VIP by one of the most experienced colleagues I know in ultrasound. I can say the name. It was because we are in Qatar, so I can speak about. It was Rabbi Shawi, who is known to you all at conference, but it can happen even if you are experienced. It's to so you don't need, you have to have a lot of respect for amniocentesis. What happened here, you can see that the amnion completely detached, weeks and weeks of being afraid of a premature rupture of the membranes, because this is the most frequent complication. Why? Because the amnion is not connected anymore to the vessels of the uterus, and then you have rupture of the membranes. If you don't have rupture of the membranes, with each movement, the amniotic cavity will turn, and then you have strangulation and fetal demise. Nothing happened here, but it's a very serious complication. Complete chorioamniotic dissociation. Now, a clip of an amniocentesis, how it is done, and I will go through the steps one by one. And I took the clip before doing the lecture. It's an old clip, but I went through it yesterday, and I think I'm doing every step what I said now in the movie. Try to follow. So this is the bowel, the area you should not puncture, okay? This is the amniotic fluid area, which is our target. Not the placenta, because the placenta will bleed. So we need to go a bit aside, okay? Now, you place the transducer, you move it to the side, the area is disinfected, and I usually use some colored one, because the patient will remember he has done some disinfection, because it's difficult to take out, okay? Now, look at the angle between the needle and the transducer, okay? This area is not touched anymore. This is the sterile area. You enter, you have to stop at the myometrium. The needle is here, okay? The tip of the needle is here. Sorry, I go away. You stop, and then it's a very rapid movement to be in the amniotic, okay? Now, we do it, the transducer is held, I'm looking at the monitor, okay? And a nurse or an assistant will take the fluid. And usually we use the most experienced one, and this is people we had the discussion about nurse, leaving from other institution. These are people we trust and with whom we work many, many years, okay? So she's taking the fluid. Sometimes the hand calm or so. Keep calm, nothing happened. If you feel it's a challenging situation, but in families with known genetic disease, they come very early and they want to exclude a condition like muscular dystrophy or any other genetic disease. So it's a referral by genetics to an early CVS. Thick nuchal translucency is another one, and I will do it between 11 and 13 weeks. The needle is a bit thicker, it's a bit more painful. So for the CVS, I will use an 18 gauge needle, and I will always, majority do a local anesthetic, okay? Because it's really painful. So I will anesthetize the skin, the area under the skin, and then use the thick needle. Same procedure, another clip, okay? It's exactly the same thing. With the same only difference that the local anesthetic is used and also used as a guidance. So I will use the needle of the local anesthetic to know exactly where I'm heading with the needle. You will see it in a moment. Okay, let's go a bit faster. Not the maternal, but the fetal. Okay. and then you aspire, and then you can check if you have enough sample. I'll show you another clip. This is an easy one. The indication, thick nuchal. There is the needle here, and you go, this is done freehand, okay? And you can use a trocar, you can use other technique, but I think most of us will do it freehand, like this. And I show you another one, which is a bit more challenging, okay? There is the needle, you don't have enough room, so you have just this small room here to navigate, because the bowel is behind here, and you don't want to touch the bowel, and you don't also want to go into the amniotic cavity, okay? It's not the purpose of the procedure. This one is even more difficult, okay? So, yeah, we say, why does he have so many clips of all this CVS? Because I record every procedure. If there is a problem, I can go back and show where I was with the needle. I have a big respect from invasive procedures, okay? So, this is done here. The needle is very navigating between a small corridor, okay? And then we go away. And the last one is this one. I think at Hamad is the most difficult ones. I tell you why. Because many patients, they come from abroad and they are in a hotel, and you cannot tell them, I'm not doing it because, you know, it's not good conditions, or I feel you nervous or so, and sending them back. So with CVS, we have usually, you know, to use all means that we have. And I show you this one. You see, it's almost a posterior placenta, and we use the small corridor to do the CVS, okay? Because they come with big expectation and they want it done. So there are some tricks how to do it. If, you know, you can either fill the bladder or empty the bladder, and you will see that the uterus will come forwards or will be back, and you play with the bladder to get the placenta in the right trajectory, or sometimes it's just to wait 1 hour, 2 hours, and then you can be surprised how the uterus change its shape, and then you can do the procedure. The last point is fetal blood sampling. Very low rate of complication, okay, but if you do it right. Fetal blood sampling, if I have the choice at 32 weeks between an amniocentesis and the fetal blood sampling, I will do a fetal blood sampling. It's much safer, especially in an anterior placenta. Again, you are with the needle in the vascular structure, you don't enter the uterus cavity. Doing an amnio is always a difficult situation. It can be a difficult situation. Necessary when suspected fetal anemia. Some patient may choose to have a genetic test very late in pregnancy, some genetic disease, whatever, where blood is needed. Chorecentesis is still, you know, indicated from time to time. The only thing is after 26 weeks, when the fetus is viable, or 24 weeks in some institution, I will do it as an inpatient. If something arises, 26 weeks, let's say, I will admit the patient, do it the next day, and discharge maybe in the evening, okay? So, this is a typical indication for a chorecentesis. We do many in Germany, we have done many. I haven't seen it in Qatar. I don't know if it's maybe because we are in this region of the world. Parvovirus B19 infection at around 18, 19, 20 weeks. Ascites, severe anemia, and you can not treat. Some will resolve from alone, but the standard is to do as soon as possible blood puncture and to give blood to this fetus, okay? So this is ascites with fetal anemia at around 18, 19, 20 weeks. We are lucky because it's an anterior placenta, okay? And we will target the cord, and this is how it is done. So it's exactly the same technique. If you use the 45-degree technique, you identify the cord, you move the transducer to the side, and you go with the needle in the umbilical cord. Very, very easy. It's a bit more difficult if it's a posterior placenta. So, this is the umbilical cord insertion. You go, the needle is here, has an echogenic tip. You wait, and you go fast, but you don't pass the umbilical artery. You will see it in a moment. Okay? 1, 2, 3, and then you are inside. Okay? You are inside the umbilical vein. If you hit the umbilical artery, you have a spasmus, and an immediate bradycardia, usually. So you have to target the vein, and then you are on the safe side. Now, the fetus can come, and some institution will inject some, not anesthetic, but muscle relaxant. But usually the technique we use is to go back if we are unsure and to go inside again. As long as you are in the placenta and in the umbilical vein, nothing can happen. If you pass the umbilical vein, it will start to bleed and you have a worse situation. And then you start to transfuse, okay? So this is blood given through a needle here, and you can see the bubbles in the umbilical vein, and it takes few minutes, and then the transfusion is done, and then you can look at the fetus later on. This is another Parvovirus B19, okay? And it's with pericard effusion, and not ascites. They can have many phases, but it was an MCA of above 50 centimeter per second at around 18, 19 weeks, and the placenta was posterior. These are not late gestation, these are early gestation, but the image is magnified to be sure where you are. Now, the problem here is you have to enter the cord, give the blood, and when you exit, you will have some bleeding. But you have to give a bit more blood because you expect the bleeding from the cord, okay? But what happens if you enter and you hit and you perforate the cord and you are not able to give the blood because now you don't see anything with all the bleeding, you lose the fetus. It's very simple as that. So, you are in the cord, okay? And then you start to perfuse, okay? I think you will see it in a moment, okay? So, no, it was just when you go out from the cord, okay? It was the end of the transfusion. And then you see, when you retrieve the cord starts to bleed. And it can bleed really a while. So you have to give enough blood to anticipate. So the posterior placenta with the posterior cord are the more challenging one for transfusion. The anterior one, you see here, this cord will bleed and bleed and bleed and bleed. But I will stop in a moment because otherwise it will take 2-3 minutes. Very important, if you do it later for fetal anemia, this patient has to be put on a CTG until you are sure everything is okay. But they can start bleeding 2-3 minutes after the procedure, and then you have fetal anemia, bradycardia, and then you have to deliver by C-section. I will stop here. Thank you very much for the attention. And I hope you